Hello there, my name is Karen. I'm the training manager at Lamelle Research and Lamelle Pharmaceutical, and this is the recording for the Nia-Sol training. I hope you enjoy it with me. Right, so what is Nia-Sol? Well, Nia-Sol is a product range that is focused on the management of actinic keratosis. So what are actinic keratosis? Well, we're going to look at them in great detail, but the easiest way for me to explain it is those hard, dry bumps or pieces of skin on older people that are generally related to sun damage. So in this picture, you can see these little areas of dryness. These are actinic keratosis, okay? A light-skinned male, you can see this patient's been in the sun. You can also see the whole area is actually damaged. It's not just this dry spot. So typically, these areas are dry, they flake, right? They're not painful, they're not uncomfortable. They're just these dry spots. And then the patient starts scratching them and they flake and flake until the point where they've scratched them till they start to hurt. Okay, so those are what actinic keratoses are. What is this an indicator of? Actinic keratoses are the precursors or can be the precursors to skin cancer. So in medicine, these are the skin cancers that get burnt off every year so that they don't convert to become non-melanoma skin cancers. And that's why we want to remove them. So it's not a cosmetic challenge. It's about the fact that we want to protect the patient from skin cancer. And that's why this treatment is so very, very important. So we talk about accumulated oncogenic mutations that might lead that are atypical keratinocytes, and they might lead as AKs or as squamous cell carcinoma. They can also form basal cell carcinoma. All right, so that's what actinic keratosis is. Actinic, the sun, keratosis, buildup of keratin. All right. The second term that you need to be familiar with is field cancerization. Now, field cancerization, if I can remind you, this man's bald head is field cancerized, all right? So that he has field cancerization of his bald head. And that is, what it indicates is the fact that this patient has, oopsie, now it's gone too far forward. There are alterations of the cells in the skin that doesn't appear to be dry and raised. All right. So that whole area of skin is actually mutated, and there are genetic alterations in that area. Okay, so when we look at using Nia-Sol, we're not only going to focus on the dry spot, but we're going to focus on the whole area because we realize that that whole area needs to be treated. So how are these actinic keratoses diagnosed? Well, generally they are flat, thickened papillar plaques. They can be white or yellow. Sometimes they can be gray in color, and sometimes they even are a little bit brown, right? Depending on the patient's skin color. The area surrounding is generally red and bubbly. We can see the changes of aging, and generally they might be a little bit tender because the patient scratched them, but they're generally not painful, right? What is the underlying problem? The underlying problem is that the patient has been in the sun, has spent a lot of time outdoors, and they have associated to that immune suppression. So the skin doesn't recognize the DNA damage, and there is overt DNA damage to the cell. So when we go and look at normal DNA, we have all these nucleotides, or they are amino acids, of course. And what happens is, for some reason, with the sun exposure, these DNA molecules have become mutated and there's damage to the DNA. Okay, so the cells are not proliferating in the way that they should. They're not forming as they should. When we look at incidence, 60% of Caucasians aged 60 years or older who have grown up in sunny environments do have actinic keratosis. 10% of those will become squamous cell carcinoma within a 10-year period. All right. The larger the area of field cancerization, of course, the higher the risk of reoccurrence. So in many cases, I know the patients tell you they've come back. They actually haven't come back. That area is just abnormal, and the cells, it's another place in that area of field cancerization that is now formed actinic keratosis. When we have actinic keratosis, you have a 6 times greater risk of developing a skin cancer. And we now know that 65 to 90%, 97%, so nearly 100% of squamous cell carcinoma would previously have been diagnosed as an actinic keratosis. Okay. So what we also need to realize is that 10% of them can form into squamous cell carcinoma, but the other 90% do spontaneously go away. Right? If they're on treatment, they do go away. And that happens over a period of time as well, generally between 10 and 12 years after the initial actinic keratosis was formed. Right, when we go and look at the incidence, there is definitely a higher incidence in men. And you can see that the age group where we see the most actinic keratosis is from 65 to 80, right? That's in our men, the same with women, 65 to 80. Even though the incidence is lower in females, men have a higher incidence. Now, I know you're going to say it's because men don't wear sunscreen. That might be true. Men also have a lower resistance to the sun, right? And of course, they've got those bald heads, poor men. All right. Okay, so incidence is more in older people. It doesn't mean that our younger people are excluded, all right? We start to look at solar keratosis from age 50 on in light skin with patients that have been living in sunny environments for all their lives. And also another place where we do see AKs is patients that are on immune suppressive medication, specifically patients that have had organ transplants, right? So they'd also have a higher incidence. Now, when we look at skin cancers and the general skin cancers that we get, we categorize them into 3 types. Actually, into 2 types initially. So you have non-melanoma skin cancers. Those would be squamous cell carcinoma and basal cell carcinoma. Melanoma, of course, is related to the melanocyte, right? Now, when we're talking about Nia-Sol, we're only focusing on basal cell and squamous cell carcinoma. We cannot make any claims with regards to melanoma. And the reason why is that melanoma is a very fast progressing type of cancer. The melanocyte has apoptotic genes, so it's very difficult to treat. And they are generally treated with surgery as quickly as possible to try and get the whole lesion out because it spreads very, very quickly. All right. Basal cell and squamous cell carcinoma aren't less dangerous. They also spread. They just aren't as fast spreading. Squamous cell carcinoma is actually more invasive than basal cell carcinoma. And of course, squamous cell carcinoma is related to the keratinocyte, the viable keratinocyte. Basal cell carcinoma is related to the basal cell. Right. Okay. Not our place to diagnose. All right. So the first challenge is the fact that we have the sun, which either can burn down onto the cell and cause a direct DNA dimer, which is the cyclopyrimidine dimers, right? What they also cause is 8-oxo-G dimers. Those are caused through free radicals. So we have direct and indirect DNA damage. Now, what is the challenge with this? Well, when we have a dimer, that makes the functioning of the cell abnormal. And when we have constant damage of that cell in the same space, that then accumulates and that then relates to the actinic keratosis as well as cancer formation. Now, in our bodies, we have a process called NER, nuclear excision repair. So our bodies do fix these. But when we are sun exposed, it affects the immunity of the cell. So the immunity is decreased, so it doesn't recognize the DNA damage. And also what happens, and you'll see that later on, is that the sun actually depletes the energy of the cell. So in many cases, the cell doesn't recognize the DNA damage and it cannot fix it because it just doesn't have the energy to do so. All right, so that's the initial challenge. We have DNA damage through UVA, UVB, and we now know that visible light and infrared also creates this damage. We have these photoproducts that are produced. Photoproducts means that there's a damaged area in the DNA. Nuclear excision repair is the predominant removal way for our bodies to do that. It removes the actual broken amino acids or nucleotides and replaces them with healthy nucleotides. As I said, the energy is low. P53, the challenge is sometimes that damage is on P53. Now, P53 is a controlling gene. Now, when that gene gets damaged, then the cell's not going to function properly. And of course, I've already spoken about the accumulation of photoproducts and the immune suppression that's surrounding that. So that's our first challenge. Our second challenge is the fact that glycolysis is affected. So glycolysis is the first process that initiates the energy levels, that initiates the energy production in a cell. All right. So we have glycolysis, that's the anaerobic effect. And then we have the second processes and third processes that produce energy for the cell. Now, if glycolysis doesn't take place, where we've got glucose that becomes pyruvate and produces ATP, the cell just doesn't have the energy to produce the energy to actually fix the DNA damage. All right. So when we look at the key effects that this sun has, the first is free radical formation. So free radical formation will cause oxidative stress and will cause DNA damage as well. And it, of course, damages the cells. We have DNA dimer formation, which we've already spoken about, direct and indirect. The energy of the cell is lost, so DNA is no longer prepared. So that's through the blocking of glycolysis. And we need a lot of energy for DNA correction. It's one of the big energy users in our cells. Our immune suppression means that we have accumulation of cell damage. And of course, the sun triggers inflammation. You can see that on that patient with a field cancerization. And that's related to a specific cytokine called PGE2. Now, when we want to fix the cell, we need to look at those processes. We have the free radical production, immune suppression, cardiogenesis, and the energy levels that are lowered. So our therapeutic objectives, when we are looking at treating actinic keratosis and also preventing the conversion of actinic keratosis to squamous cell carcinoma, what we need to do is, firstly, we need to protect from the sun. So we need to educate this patient, and I know that sometimes it's a difficult task. All right. They need to use sun protection or they need to stay out of the sun. They need to wear their big hats. All right. The second thing that we want to do is we want to restore the cell's energy. All right. So that cell can fix its own DNA damage. We want to enhance the dimer correction as well. So we want to add an ingredient that can help the cell to remove the DNA damage. We want to lower inflammation. And the ultimate result is that we want to reduce the incidence of AKs, but also non-melanoma skin cancers. Okay. And that's where our Nia-Sol is going to come into it. All right. So Nia-Sol was based on 3 trials that were done called the on-track trials. So we're going to talk about the final trial, but there were 2 precursors to this trial that looked at the use of oral nicotinamide to reduce actinic keratosis, right, or actinic cancers. That's what on-track stands for. These were Australian trials that were done. And and we'll have a look at what they showed. So when we go and look at nicotinamide, of course, is a form of vitamin B3. All right. So nicotinamide is niacinamide. Please note it's not niacin. Niacin causes flushing and irritation. We're not using that form of vitamin B3. Right, now if we put nicotinamide into or onto your body, it is metabolized and it becomes nicotinamide adenine dinucleotide. And NAD is essential for the process of glycolysis and the production of ATP. Okay, so it leads to energy in the cell, right? Okay. Oh, nicotinamide, not niacinamide, that's another form of vitamin B. Now, nicotinamide, as the forerunner of NAD, so what NAD does is it helps with glycolysis. It enhances cellular energy. It also helps with the respiratory train, which is the next phase of energy production, right? It assists DNA repair, right? And I mean, those are the different forms that can all form NAD. Okay, so in the trials, what they did is they used 500 milligrams of oral nicotinamide, okay, actually, they used 1 grams of oral nicotinamide. If you use 1 gram of oral nicotinamide, it increases the NAD by 30% within 1 hour. All right. So double that, you double the dose. Now, unfortunately, we have a natural decline in the amount of NAD in our bodies with time. So from age 40, we actually decrease the production of NAD, and we have to take it. We have to take something to supplement that, and that's where our nicotinamide mononucleotide will come in, or NMN, right? Which will then, of course, increase the NAD. So, how does nicotinamide help us in our aim? So, the first thing is that it improves DNA repair. It enhances DNA repair. It inhibits immune suppression. It reduces inflammation. And it restores the energy levels of cells. Okay, and we're using nicotinamide in all the products in the Nia-Sol range. So let's go and look at this, the on-track trial. So the on-track trial was a precursor. So this was the first trial. So this was the phase 2 double-blind study. And here they had, these were the 2 first phase studies, okay? So you can see the groups were reasonably small. Men and women were used, and they had placebo groups, and they had, so this is the variance. And of course, we always will have more men because the incidence is higher in men. And what they saw is they did see definitely a positive effect on the amount of actinic keratosis, as well as on the conversion of actinic keratosis. Let's go and look at the full trial, the third trial. So it was a phase 3 trial. It was a double-blind randomized controlled trial. What does that mean? It means that neither the tester or the person drinking the tablets knew what was in the box. It was randomized, so you couldn't choose which group you went into. You were given a number, and then you went into the group, and there was a control arm, which means that you've got a placebo arm, okay? Initially, there were 386 patients, and they had to be, let me put the red bits in. So 386 patients, they had to have at least 2 non-melanoma skin cancers in the previous 5 years. They received 500 milligrams of nicotinamide twice daily, right? And the trial actually ran over 18 months. So they received their medication for 12 months, but the trial ran over 18 months. Primary endpoint was to look at non-melanoma skin cancers, and the secondary endpoint was to look at the number of new actinic keratosis over a 12-month period. All right. So just with regards to the trial design, 433 patients were screened, 386 went into randomization. We had 193 patients in each group. All right. There were some patients who were lost to follow up, generally because they couldn't make the final appointment for their follow-up. All right. In the one group, there were 4 patients who declined participation. One was too unwell to attend. There were patients that passed away. They passed away because of their age, right? Okay, so we have 192 patients finishing, which is a very good rate of staying on trial. and 191 in our placebo, in our other group, in our treatment group. So placebo group, 1 patient fell out, and in our treatment group, 2 patients fell out. Okay. When we go and look at the number of actinic keratosis, it decreased drastically. That's statistically significant decrease, all right, when compared to placebo. Right, so depending on when the follow-up was done, our first patients, there were 11% less, 14% less, 13% less, and 20% less. Now, what we have found, just interestingly, is the patients that are taking the oral supplement, they note, so how they measure their results is by the amount of actinic keratosis that their dermatologists need to remove on their 12-month visits. And we've had patients that have gone from many actinic keratosis to hardly any actinic keratosis being removed. So we would improve on that data. All right, remember this is an average. Okay, so that's on the nicotinamide, the oral nicotinamide. Then Dr. Bradley said, well, we can enhance this effect. So in the on-track trial, they just looked at the 500 milligrams or 1,000 milligrams of oral nicotinamide a day to decrease the amount of actinic keratosis and decrease the conversion. But in our range, we've got a gel and we've got a lotion. Right. Now, the gel and the lotion contains this photolyase enzyme. What photolyase enzyme does is it finds and it fixes DNA damage. All right. So we're enhancing that effect. So what it does is it uses visible light as an energy source. It finds the CPDs, it binds the CPDs, and it releases them so that you have a cell that has the normal DNA activity after you've applied the photo repair product. So it finds it, it repairs it, and you have activation of the healing effect. All right. So our photolyase enzyme reduces CPDs by 40 to 45% in an hour after it's applied. Okay. In sunscreens, it reduces CPDs by 93%. It reduces MMPs. Now, MMPs are the enzymes that eat your collagen and elastin by 90%. And we know that it reduces actinic damage. All right. If we look at nicotinamide, it reduces immune suppression, it improves DNA repair, reduces inflammatory cytokines, reduces actinic keratosis, reduces non-melanoma skin cancers. And when we apply it topically, we see a 22% improvement in the reduction of actinic keratosis over 3 months. And that's at a 1% gel. Now, we've used 3 and 4% in our gel. Okay. So who are our patients? Well, our patients, firstly, we want to work with Fitzpatrick skin type 1, 2, and 3s that have a family history of cancer. All right. It increases, if you have a direct family member that has skin cancer, it increases your risk by 60% of getting skin cancer. All right. And especially if those patients have an outdoor lifestyle and they live in sun exposure. That would be anybody in South Africa. So that's our first patient, our prevent patient. Our second patient, we are treating AKs, and we want to prevent the conversion of AKs to skin cancers. All right, so those patients are already going to the doctor. And then our third group is our treatment group where they have had transplants. So please, in our treatment group, the Nia-Sol can definitely be combined with other treatments. Okay, so where the patient is having Aldara, or they're having light therapies, or they're having lasers, or they're having them burnt off, they would still continue on their Nia-Sol program. So when your patient is on imiquimod, that would be Aldara, would be the name for the product. We would definitely consider topical lotion BD, all right, cryotherapy, topical lotion BD, PDT, topical plus oral, and when they're having the excision, topical plus oral. Okay, in the treatment phase. All right, when they go off the treatment phase, then they go on to both. Okay, so with regards to safety, there are no adverse events. All right, we haven't had any adverse, sorry, No, we haven't had any serious adverse events at all. All right. There's no challenges with regards to blood pressure and weight. Liver function isn't affected, kidney function isn't affected. So anybody could really use it. When we look at oral nicotinamide, doses of 3,000 milligrams per day have been used for many years without any side effects. And patients with bullous pemphigoid or Stevens-Johnson's, they'll use 1,500 milligrams a day. So that's 3 times the dose that we are suggesting. All right. So what's in our range? Well, of course, we have our oral supplement, which contains 500 milligrams of nicotinamide per capsule. Your patient needs to take 2 a day. I know the box says 1 a day, all right, but your patient needs to take 2 a day. Ideally, you want to take it in the morning and midday, but we do understand that it's very difficult sometimes to adjust to that routine. I take mine early morning, all right, with all my other supplements. It does contain some Pinus pinaster or pine bark extract for its antioxidant effect. And there is 100 units of vitamin D3 in there, just to help a little bit with D3. It's not going to replace deficient D3 though, all right? You need 1,000 units to do that. Then we have our Nia-Sol gel, which contains a 4% nicotinamide and a 1% phytolyase enzyme. So the gel, the idea with the gel is that you're going to use it on the actual actinic keratosis. You will also know that we now have, so the little gel comes as a supplement or a free product with your capsules. We also now have it in a big tube. Right, if I'm correct, I think it's a 70 ml tube. We developed the 70 ml tube for specifically men who feel that the lotion is a little bit too oily, though I don't know how they do that. Okay. And then the lotion is actually ideally developed for the areas of field cancerization. So in the lotion, we have a 10% ceramide complex. Of course, we know that that barrier is impaired in that area. And that's why Dr. Bradley added the 10% ceramide so that we can improve the barrier of the skin. 1% phytolyase, so we can find and fix the DNA damage. 3% nicotinamide, okay. Also, energy to the cell, improving conversion of actinic keratosis, decreasing the incidence of actinic keratosis. Remember that 30% in 6 weeks, I think it was. All right, decrease. Hyaluronic acid is for hydration and panthenol is to calm and soothe. All right, so your patient's going to take 2 capsules orally every day. They're going to use the gel on the actual spots, and then they're going to use the lotion all over the area of field cancerization. And then, of course, they're going to put their sunscreen on top of that. Okay, so Nia-Sol is there to reduce the risk of AKs, reduce immune suppression, reduce the risk of new non-melanoma skin cancers. Just a reminder, we're not taking it away completely yet. Enhance DNA repair and restore the cellular levels of energy. Thank you very much for joining me for this training. I hope to see you in some other trainings. Keep well.